Hello everyone, my name is Lisa Cordes and I'm an oncology clinical pharmacy specialist at the National Institutes of Health. I'm happy to be here with you today to discuss the case of a young woman with renal cell carcinoma who's currently being treated with an immunotherapy regimen. As Dr. Gully discussed in his presentations, immunotherapies have really revolutionized the treatment of our patients with cancer. More patients are responding to treatments, their responses are durable, and they're really living longer. However, with immunotherapies comes autoimmune toxicities that require a completely different treatment approach than toxicities seen with our traditional cytotoxic chemotherapy. So why do autoimmune toxicities occur with immunotherapeutic agents? So Dr. Gully went over this in his slides, so I'm only going to highlight a few important points. Self-tolerance is partially maintained by the inhibition of T cells through the CTLA4 and PD-1, PD-L1 pathways. So if we inhibit these pathways by using drugs such as ipilimumab, which inhibits the CTLA4 pathway, or nivolumab, which inhibits the PD-1 pathway, that unleashes the T cells and that leads to the potential for autoimmunity. What's interesting about these toxicities is that any organ system can be involved. So that can be the dermatologic system, it can be cardiac, it can be the neurosystem. Really, no system is safe. And so it's important to counsel your patients to be on the lookout for toxicities that occur with any of these organ systems. Also, the onset is variable. So you can give one patient one dose of an immunotherapy and it can cause an autoimmune toxicity. Or it can be months and months after they've stopped the treatment, and then at that time they could have the toxicity. So our patient Rebecca is a young and otherwise healthy female with metastatic renal cell carcinoma. At this time, she's received 3 doses of ipilimumab and nivolumab, and she was just admitted to the hospital. Rebecca is meeting with her oncologist, Dr. Redmond, right now. Let's listen in.
Hi, Rebecca. Sorry to hear you're not feeling that well. What's been going on?
The past few days haven't been very good. I started having really bad diarrhea. I have to go to the bathroom about 10 times a day when I usually only go once. I also have severe abdominal cramping. It feels like someone is twisting my intestines.
Sorry to hear that. Looking at your blood pressure, it's a little low, and your labs show me that you're a little dehydrated. I think this is all due to an inflammatory process in your colon. And we can treat it with steroids, but I'd like to admit you just to get treatment started.
Okay, so let's pause for a second. What grade of colitis is Rebecca currently experiencing? For grading, we reached to something called the CTCAE. This was put together by the National Cancer Institute, and it's a common terminology criteria for adverse events. Essentially what this is a descriptive terminology that allows us to commonly assess adverse events that our patients are experiencing and name them in the same way. So as Dr. Redmond mentioned, her workup revealed an inflammatory process in her colon, which means she has colitis. So we go to our CTCAE term for colitis, and we see that it's graded on a scale of grade 1, which is minimal toxicity, all the way to grade 5, which is patient death. So as Rebecca mentioned, she has severe abdominal pain. So if you look down, you can see that it's a grade 3 toxicity. So once you've determined the grade of the adverse event, you could then use the treatment guidelines to determine the next best treatment strategy. There are multiple different treatment guidelines available for autoimmune toxicities, and they're listed here for you. We have ASCO, ESMO, SITC. We also have NCCN, or the National Cancer Comprehensive Network, and they have the management of immunotherapy-related toxicities, and we're just going to highlight them for an example today. As you can see here is our initial treatment strategy for colitis. And Rebecca has a severe toxicity, which means she has a grade 3 or 4 toxicity. First, we're going to hold the immunotherapy regimen and not give it until we figure out what's going on. We can consider inpatient care. In Rebecca's case, she was admitted to the hospital for supportive care. So we want to give her some hydration because she was dehydrated. And we also want to correct her electrolyte imbalances to better care for her. We'll also start steroids, as Dr. Redmond mentioned. The recommendation for a severe colitis is IV methylprednisolone at a dose of 2 mg per kilogram once every day. So as we mentioned, the patient was started on this steroid dose, and the oncologist is rounding on her now. So let's see how she's doing.
So you've been on steroids for about 2 days now. Are you feeling any better?
Honestly, I don't think it's gotten better. I still have persistent cramping.
So as you've heard, Rebecca's colitis has not improved. She still has a lot of symptoms. So now we think, okay, what is the next best step in managing this adverse event? So again, we go back to our NCCN treatment guidelines and we look for steroid refractory treatments. And so as you can see, if there's no response to the steroids that we initiated within 2 days, we want to look for another treatment option. So here we're going to continue the steroids, but we're going to add an agent called infliximab. Infliximab is an agent that's FDA approved for different types of autoimmune diseases, such as Crohn's disease and different types of arthritis. And it inhibits something called tumor necrosis factor alpha. Essentially, TNF-alpha is involved with pro-inflammatory biologic activities. So what we're going to do is we're going to use the infliximab, come in and inhibit TNF-alpha, and that's going to inhibit the inflammatory process that's currently going on. So as we recommended, infliximab was added to Rebecca's regimen and her symptoms quickly improved. So at this time, the methylprednisolone can be transitioned to an oral prednisone regimen and then tapered over about 4 to 6 weeks. We taper over a long period of time so that the symptoms don't flare. If you taper too quickly, we actually might see a recurrence in her symptoms. So while she's on the steroids, don't forget about whether we need PCP prophylaxis, fungal prophylaxis, or a proton pump inhibitor. Patients like Rebecca are seen every day in our clinic, and we hope this case provides you with some insight into her treatment strategy for autoimmune toxicities. We do recommend that you refer to the treatment guidelines and prescribing information for further details on both the diagnosis and the management of these unique toxicities. Thanks so much for watching.